All right. So I've been tasked with, we thought it would be just helpful to go over melanoma prevention and kind of where we are with, I think I gave a talk similar to this for an AMET melanoma patient symposium like 5 years ago. And there's been such an evolution in, UV clothing and other, just other options. And so just hoping to go through that today. So we're going to just go over some, I termed it anatomy, but just some of the basics of melanoma, UV radiation, move into sun protective measures such as sunscreens, UV clothing, tanning. I don't probably have to tell this crowd the dangers of tanning, and then early detection, and just briefly on genetics. So certainly this is a cross section, just reviewing the anatomy of the skin as we talk about UV radiation. And so I try to draw this out for patients in clinic when we talk about melanoma. So the upper layer is the epidermis. That's where tell folks that's where kind of the skin cells can slough off deeper into the dermis. That's where you have your blood vessels, your lymph nodes, your nerves. And so the melanocytes kind of sit right in between that layer, as you can see in the, I'm not sure if you can see my cursor there, but right in the middle there, in between the basal cells and the squamous cells are above that. And so that outermost layer, the epidermis, is really protecting us from the environment, trying to be a moisture barrier. The dermis is the thickest layer next below that. And then the subcutis is further down. That's where we have our fat and fibroblasts. And so melanocytes are found throughout the body. And I think for patients with cutaneous melanoma, that does not come as a surprise. For patients with uveal melanoma, mucosal melanoma, even acral, where we're diagnosing melanoma on the palms of hands, soles of feet, underneath nails, it can be a little surprising to know that melanocytes are found throughout the body in all these different locations. One example of these melanocytes make melanin. One example of where the effect of different melanin production is in the spectrum of eye color. And so going from brown to blue, you can see that reduction in the melanin pigment. There's 3 different kinds of melanin. We won't really get into that today, but melanin is one of the primary functions of those melanocytes. And so on the far right, you can see UV damage to the skin. That UV exposure causes a lot of inflammation, and that oxidative damage sends a signal into the nucleus and causes a cascade of signaling in the melanocyte, leading to that melanin formation and transfer. And so that kind of comes back to that term of there's no safe tan. Folks that will say, oh, I need to get my base layer. There's nothing safe about that. That's still your body's signal that it's been exposed to UV, had UV exposure, and is really trying to protect itself. And so what is UV radiation? And, certainly I've seen things in the news about how, UVB or UVA is, one's actually healthy and we need it. But it's all UV radiation and still should be something that we need to be protected from. So you can see the difference in the energy and wavelengths between the gamma rays, X-rays, UV, and then down to the visible light. So the strength of UV rays reaching the ground depends on the time of day. So it's strongest between 10 to 4. The season, obviously strongest during spring and summer. Latitude, stronger closer to the equator. Altitude, stronger at higher elevations. So out in Denver, where Dr. Wade is, if you're out climbing mountains, that UV exposure is certainly going to be higher. Cloud cover may block some UV or reflect some, but even on a cloudy day, you can still get UV exposure. And then surfaces, UV can reflect off of water, sand, snow, pavement, or grass that can increase the exposure. So UVA penetrates deeper into the skin. This can cause kind of aging of the skin cells, DNA damage. It's linked to wrinkles, but can also play a role in some skin cancers. And UVB, B for burn, is the main cause of sunburn and causes most skin cancers. It does have more energy than UVA. And so the primary concern is that this exposure to UV radiation damages the DNA in those skin cells, and this failure to repair damage leaves cells with increased DNA mutations and chromosomal defects, and that this can cause uncontrolled growth in cancer. And so this is a little technical, but I always like to show this slide to just put melanoma in context of other cancers. And so what is the link between UV radiation and some of the treatments that we're going to talk about today? Well, likely because of that UV exposure and just that damage on the DNA of these cells, when melanoma develops in general, cutaneous melanoma is certainly a far different spectrum than something like uveal melanoma. Melanoma has accumulated one of the highest numbers of mutations in the DNA compared to almost any other cancer. Now, melanoma, if I don't have up here squamous cell carcinoma of the skin or basal cell carcinoma of the skin, those are also similar. But if you look across other tumor types, such as colorectal, pancreatic, glioblastoma, there's fewer mutations. So what does that mean? It means those cells look very different from the normal cells of your body. And this can, is likely why immune therapy has been so successful in melanoma. And when we specifically look at the mutations, that high mutation burden in melanoma compared to others, for the most part, what we see is the nucleotide change from C to T, and this is classic with UV exposure. And so what are, the other risk factors here for melanoma? So we have the UV light exposure, major risk factor for most skin cancers. Sunlight's the main source, but we're going to briefly talk about tanning beds. And so 90% of skin cancers are associated with UV exposure. And then skin color. So as we discussed, so melanin skin pigment, it is a protective factor. And so you can just see as the melanin in the skin gets darker, there is less sensitivity to UV, less likely to burn, and there is less skin cancer risk. And the risk factor none of us can affect is age. We know that the risk rises with age, but we still can see skin cancers even in young people. And so what are some other additional risk factors for melanoma or other non-melanoma skin cancer? So for melanoma, a patient that comes in, we may just discuss, do you have any history of blistering sunburns, especially as a child or teenager? Sometimes that can be hard to remember. And then other folks are like, oh, if I could go back now, I'd spent most of my childhood out in the sun, not wearing sunscreen, having a number of moles. So sometimes this can be hereditary, but folks that have a number of what we call nevi does increase the risk for melanoma. A family history of unusual moles or atypical nevus syndrome. Having a personal history of melanoma increases your risk of having another melanoma diagnosis and is why we always recommend close surveillance of dermatology. And then a family history of melanoma. What about those non-melanoma skin cancers that can certainly be bothersome and frustrating, especially for patients that say every time I go into dermatology, they're removing another squamous cell carcinoma or basal cell? Well, we know the presence of actinic keratoses does increase the risk for non-melanoma skin cancer. You see a picture here, and that's why dermatology does like to freeze these off or remove them. Prior treatment with radiation, so patients that have maybe had another cancer that was treated with radiation. Patients with a weakened immune system, so for example, patients that are on immunosuppression, or particularly patients that have had a prior transplant, and then arsenic. And so skin cancer is the most common cancer in the world. 1 in 5 Americans will develop some skin cancer in their lifetime. And despite this understanding of prevention, melanoma rates have doubled from 1982 to 2011 and continue to increase. The good news is basal cell and squamous cell, the two most common types are highly curable if they're detected early and treated properly. And the 5-year survival rate for people whose melanoma is detected and treated before it spreads to lymph nodes is 99%. And so certainly want to treat squam and basal cells early so they don't have a risk of local recurrence, metastatic development. But unfortunately, most skin cancer deaths are from melanoma, although we're making a significant amount of progress. And then you can just see some of the rate of the new melanomas per 100,000 people based on gender and race. So now that we've finished a little background, just going to dive into sunscreens. So sunscreens prevent UV exposure. We've already discussed a little bit to stay in the shade, try not to get a sunburn in particular, avoid tanning, cover up. And so I think one of the important things is just understanding SPF. And so you can see here with just some basic math here, there's 100 photons, for example, from the sun. Without any sunscreen, 100 photons enter the skin. With an SPF of 15, even, I think in perspective when they're selling, SPF 80, 90, it feels like SPF 15, maybe there's not much benefit there. It offers 93% protection. And so you can see just such a dramatic impact just by putting on SPF 15. And then SPF 30 offers 97% protection. And so really any sunscreen is better than none. But hopefully this kind of helps you understand that just having some sunscreen on, but there is less benefit as that SPF goes from 30 to 50 to say 80. And then screening is important. And so making sure, and we'll kind of discuss this a little bit later from this caricature here of the ABCDEs of screening. And so this is from the Skin Cancer Foundation, what are the 5 W's of sunscreen? So everyone under the sun. So this is certainly something you can take home, not for you, but also anyone else that you may be with in the summers, vacationing with, coming to your house before you're going outdoors to do activities. Even a SPF of 15 or higher is beneficial. 30 or higher is recommended for if you're going to be outside for most of the day. You really should be putting on the sunscreen 30 minutes before going outdoors and then reapplying every 2 hours, and then all exposed skin. And then how much, I think this is the challenge that's forgotten. It should actually be 1 ounce to the entire body for each application. So the example here was a shot glass full, which I think even myself, that does feel like a lot, but I think it's just a good graphic of like, that's actually how much you need to be layering on. And I think just a helpful reminder. There's only a few exceptions. So if you're less than 6 months old, should not use sunscreen due to to skin sensitivity to the sunscreens. And so for those, for babies, sun protective clothing and shade is instead recommended. Broad spectrum, when you see that, what that means is it does protect from both UVA and UVB. Water resistant, so no sunscreen is waterproof, but what water resistant means is that it's had a tested efficacy up to 40 minutes in water. And when you see the term very water resistant, it was tested efficacy up to 80 minutes in water. And so I'll get a lot of questions, or I see there's can be a lot of debate online of the different types of sunscreen. So they kind of fall into 2 separate categories. So one is the physical filters. And so the examples there are titanium dioxide and zinc oxide. These are kind of the oldest ingredients that have been used for sunscreens. So these create a physical filter that you can see there. And so that allows that UV damage does not get absorbed, but it reflects that UV radiation back off versus chemical. So examples here, the avobenzone and octisalate, these are newer still, a decade or so. So these ingredients, they absorb into your skin. So you can know after you purchase a sunscreen, I think you can tell a difference. The physical tends to be a little bit kind of whiter, chalkier, giving you that little bit of discoloration, but you can certainly feel it versus the chemical. It's a little bit more lotion feel. So these do absorb into the skin and then absorb that UV radiation. And so there's been a lot more debate about are sunscreens safe. And so while the physical sunscreens, because they're not absorbed, may be less likely to cause skin irritation than the chemical sunscreens, both types have been tested to be safe and effective. And these have all been evaluated by the anything that's for sale in the US has been evaluated by the regulatory authorities. And so when you look at the label, any of these ingredients that you see have been tested. Many of these are now combining both the physical and chemical, but oftentimes you'll be able to kind of turn and take a look and see what the ingredients are. And sometimes it's physical and sometimes it's a chemical one. So it's interesting. So the Skin Cancer Foundation, I think this can be helpful. Sometimes if you're evaluating sunscreens, they do have a panel of dermatologists that will go in and evaluate sunscreens. And so they'll put a seal. Now, the companies do have to submit their sunscreens for evaluation, and I do think there is some cost. So I think I would see this as, an extra step for companies, but if this gives you a little bit more reassurance that they have gone in and done kind of a separate testing, that the Skin Cancer Foundation has recommended sunscreens for SPF greater than or equal to 30. If it says daily use, that means SPF greater or equal to 30, broad spectrum. And if they say they're water resistant, they've actually checked it and have substantiated that. If they do have a recommended active seal, that's an SPF greater than or equal to 50. And this is intended for extended sun exposure. This can be used for baby products. Now, that would generally still mean over 6 months, but like the kids younger ages, broad spectrum and substantiation of the water resistance claims. And then they have a separate seal for sun protection products. And so I don't know about you guys, but I've been seeing this on a lot more things of UV protection for clothing, awnings, hats, eyewear, umbrellas, glass. So you can submit for this seal. That would mean the SPF is greater than or equal to 50. And hats, to meet this recommendation, hats have to have a minimum of a 3-inch brim around the entire circumference and 2.5 inches for size 5T or kids, 5T and below. And so there's now, if you type in UV clothing, these are just a few examples. This is certainly a big area of development. And I think also just a huge advantage, right, to that trade-off between, well, I want to be active. Oh, I don't want to have to put sunscreen on. And so UV clothing can be a fantastic option. And you can just see here some facts. So they, instead of going by SPF, it goes by UPF, so ultraviolet protection factor. And that's just how much of the UVA-B radiation that fabric allows to reach your skin. In general, whether it's UV clothing or not, dark or bright colors are best because they absorb the UV rays. Loose is best. Tight clothing can reduce that level of protection, and wet clothing also provides less protection. So if you've got kind of a white, shirt with a logo on it that you end up jumping into the pool and wearing, it's really not going to provide any protection versus, say, like a black long sleeve that's looser that you're able to keep dry and put on. And so UPF 30 to 49 is good, and 50 plus is best. And you'll kind of see that on some of these clothing advertisements. So just a brief word on tanning. We are certainly making a lot of progress, and we really think a lot of the interventions should be targeted at a young age, and really trying to do sun protective education as early as possible. And so there's been a number of studies that have shown that the percentage of adolescents using indoor tanning in the past year at the time of the survey has significantly dropped since 2009. So you can see over this 10-year period, went from 25% of adolescents to nearly 5%. And studies have demonstrated that teens who do not tan before age 18 are 2 to 4 times less likely to tan as adults. And so I Outdoor tanning, though, unfortunately, is now more prevalent in adolescents. So 15% still do outdoor tanning versus 3%. And a third of U.S. adults reported intentional outdoor tanning in the past year. The biggest risk factors were women being aged less than 25, and if they participated in activities near water, physical activity, or work around the home. And so these are certainly areas that we're still trying to target in the field to try to help these folks understand, right, what are the risks, and trying to make good decisions at an early stage in life to prevent any of these cancers or issues later. So just as I wrap up here, just a few slides on some early detection. I'm sure everyone here is aware of the ABCDEs, but I think still certainly just good to go through. So because if we can't prevent melanoma, we can at least try to detect it early. So the ABCDEs, A is for asymmetrical, one half looks different than the other. B, irregular border. C, if its color is variable. D, if its diameter is larger than a pencil eraser, so about 6 millimeters. And E is if it's evolving, right? So if hey, this is a lesion I've had since I was a child, but now, it's itching, it's bleeding, I'm starting to see it's expanding. And melanoma, though, while we have these kind of classic categories and characterization, melanoma can have many different appearances. And so always, if there's any lesion of concern, making sure that you're having it evaluated by a dermatologist. So self-skin exams, though, there's been a little controversy, but I think certainly for this audience, maybe clarifying. So the USPSTF, so this is the government agency that makes screening guidelines. They had recently renewed that there is not enough evidence to endorse asymptomatic adolescents or adults from doing annual skin exams and going into the clinic for this. But I think it's important to know that this does not apply to anyone who does not have any signs or symptoms of cancer, anyone with a personal or family history of skin cancer, and then anybody who meets those ABCDEs. And so it was a little challenging because this caused a lot of headlines of, oh, well, we don't need to do skin exams. But what they're saying is just if you have no symptoms, no personal or family history, and don't meet any of those guidelines, the government is not endorsing that there's enough data to say that you should go get your skin checked. But really, there's a lot of kind of loopholes in this, and anyone with personal family history concerning lesions should absolutely go in and get annual skin exams. And with the skin exams, especially for folks that have a number of different lesions, there's a lot of technology under development. These are some examples of mole mapping, being able to track some of these lesions that may be characteristic for a patient, but really want to be followed. And then a shout out to the OHSU or Oregon team. I know really led by Dr. Sancy Leachman. This is the Mole Mapper tracking app that I believe is free to use and is one of many that I think are really trying to use digital technology to try to help patients be able to track their lesions, help their providers be able to follow these closely. OHSU also has an online education if you wanted to learn more. It's a free module for melanoma early detection that you can go to the link below, be able to click on and kind of educate yourself from their dermatology team. And other things for skin cancer prevention, there's been a number of kind of studies in trying to look at things like beta carotene, unfortunately no evidence, retinoids or vitamin A compounds, because we know that this can be helpful in preventing skin cancer for patients that have xeroderma pigmentosum. But unfortunately for the general population, no data to support that. Vitamin B3, there's been some mixed results showing maybe this can decrease actinic keratosis formation by delaying that, but a higher risk of non-melanoma skin cancers after treatment. Selenium may decrease basal cell, but may increase squamous cell. So you can see we start contradicting ourselves. And then celecoxib, it's a specific NSAID, did slightly decrease recurrent basal cell squam in those with prior disease, but can increase cardiovascular issues. And so just a quick word on genetics. When we think about melanoma prevention, we are learning more about, beyond the characteristics of, I have a family history of melanoma, so I need to get my skin checked, or I've had a history of 2 melanomas and I'm fairly young, or I have 2 cancers now, including melanoma. And we are learning more about a number of syndromes listed here, like Li-Fraumeni-Cowden syndrome associated with, so Li-Fraumeni is associated with TP53, Cowden syndrome with P10, and then BRCA, and then certainly learning more about CDKN2A mutations. And I kind of highlighted that here because patients that do have a history of 2 cancers, insurance in general pays for genetic testing. That can either be, it's ultimately a blood test, but if it's unclear, you can meet with a genetic counselor. They'll go through a patient's history. They kind of diagram it out, like shown here in the bottom right, of who's been affected, what age, what types of cancer. And this can be helpful for some patients just to really understand their risk, not only of melanoma, but maybe other cancers. And I included here our medical oncology guidelines for CDKN2A. You can see that with this mutation, the absolute risk of developing melanoma is 28 to 76%. And these are patients that also have a high risk of pancreatic cancer, potentially depending on their mutation, sarcomas. And so it can be helpful to just talk to your provider if you have a history of multiple cancers or a very strong family history of cancer to see, should I be getting tested? And so ultimately, our goal is primary prevention in melanoma and skin cancers. So early UV protection, identifying high-risk individuals so we can do close surveillance and really diagnose any of these kind of atypical lesions or melanomas early on while they're still very curable. And so I would be happy to answer any questions at the end of our session today. So go ahead and submit them into our Q&A, and we would love to circle back on those.